Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session I will be discussing a very important topic in the neurology, that is the Duchenne Muscular Dystrophy. So Duchenne Muscular Dystrophy, it is a congenital muscular dystrophy and we have many forms of the congenital muscular dystrophies. Out of which you see this question, the most common type of congenital muscular dystrophy is Duchenne muscular dystrophy, Becker's limb girdle muscular dystrophy, facioscapulohumeral muscular dystrophy. So the most common type of congenital muscular dystrophy is the Duchenne muscular dystrophy. And you need to know what exactly is the problem in the Duchenne muscular dystrophy. Duchenne muscular dystrophy, it is a disease of neuromuscular junction, sarcolemmal proteins, muscle contractile proteins, disuse atrophy due to muscle weakness. So let me tell you, the Duchenne muscular dystrophy, it is a disease of the sarcolemmal proteins, right? It is a disease of the sarcolemmal proteins. Now, I'll just show you one important clinical scenario and then we will discuss this. A 10-year-old boy with a large leg muscles and increased levels of the CPK-MM is suggestive of the diagnosis of. So you take the CPK-MM that is elevated in majority of your congenital muscular dystrophies, but the type of congenital muscular dystrophy with large leg muscles, that will be the Duchenne muscular dystrophy, right? That will be the Duchenne muscular dystrophy. Now, why does this and how does this Duchenne muscular dystrophy occur? Let me discuss. Duchenne muscular dystrophy, it is caused by mutation in the gene responsible for producing dystrophin, right? Mutation in the gene responsible for producing dystrophin. That is what is your Duchenne muscular dystrophy, right? It is caused by mutation in the gene responsible for producing dystrophin. And what is this dystrophin? Dystrophin, it is a subsarcolemmal protein. Right? It is a subsarcolemmal protein. And where is it localized? It is localized to the inner surface of the sarcolemma. Right? It is localized on the inner surface of the sarcolemma of muscle fiber. Right? Inner surface of the sarcolemma of the muscle fiber. And this particular dystrophin, let me tell you, which is a subsarcolemmal protein, it is a part of dystrophin glycoprotein sarcolemmal complex. Right? It is a part of dystrophin glycoprotein sarcolemmal complex. And this protein deficiency leads to secondary loss of sarcoglycans and dystroglycans. Okay, this protein deficiency leads to secondary loss of sarcoglycans and as well as the dystroglycans. Right, secondary loss of sarcoglycans and dystroglycans. And because there is secondary loss of sarcoglycans and dystroglycans, that results in weakness of the sarcolemma, right? That will result in that results in the weakness of sarcolemma. And because of the weakness of sarcolemma is what? It is the muscle membrane, right? So because of weakness of sarcolemma, there will be membrane tears, right? There will be tear within the membrane, and subsequently there will be also muscle fiber necrosis. Right, subsequently there will be also muscle fiber necrosis. That is what will happen in these patients with the Duchenne muscular dystrophy. So everything is mainly because of mutation in the gene which is responsible for the production of a protein called dystrophin, which is a subsarcolemmal protein which is localized on the inner surface of sarcolemma, right? And due to which there is tear within the muscle membrane and there will be muscle fiber necrosis, right? And this Duchenne's muscular dystrophy, it is also called pseudohypertrophic muscular dystrophy. Right, it is also called pseudohypertrophic muscular dystrophy. So why is it called pseudohypertrophic muscular dystrophy? I'll discuss, right? I'll tell you that. And this Duchenne's muscular dystrophy, as I have already said you in the beginning, it is the most common cause of the hereditary neuromuscular disease affecting all races and as well as the ethnic groups. And if you take the inheritance of this DMD, it is X-linked recessive disorder. Right, it is an X-linked recessive disorder. And the presentation, it occurs between, right, presentation it occurs between ages 3 and 5 years. Right, presentation it occurs between ages 3 and 5 years. Right, and this disorder does not present at birth or in infancy. Right, does not present at birth or in infancy. They present between the age group of 3 and 5 years. And if you take the clinical manifestations in these individuals, the Gower sign will be positive. Right, and what is this Gower sign? See, Gower sign is that the individual will not be able to get up straight whenever he wants to get up from the sitting position or squatting position. So, from sitting position or squatting position, if he wants to get up, the individual has to climb on himself. Right, the individual has to climb on himself to get up. That is what is called as the Gower sign. And why there is Gower sign? This Gower sign is mainly because of proximal muscle weakness. Right, that is because of the proximal muscle weakness. Okay, and followed by that, these individuals, they have what is called pseudohypertrophy of the calf muscle. Right, pseudohypertrophy of the calf muscle. Now, what do you understand by the word pseudohypertrophy of the calf muscle? So here, the muscle, right, it is replaced by fat and connective tissue. Right, it is replaced by fat and connective tissue. Right, it is replaced by fat and as well as the connective tissue. That is what is the pseudohypertrophy of the calf muscle. Right, muscle will not be there. It is replaced by fat and connective tissue. And there is also loss of muscle strength progressively. Right, so progressively there is loss of muscle strength. Right, progressively there is loss of muscle strength. And in these individuals, proximal muscles and neck flexors, they are involved more. right, proximal muscles, they are more involved than compared to that of, right, the distal muscles. And the other important group of muscles which are affected more is the neck flexors. Neck flexors, they are affected more, or they are involved more. Okay, and followed by that, if you take the difference between the upper limb and as well as lower limb involvement, that is leg involvement, right, leg involvement, it is more severe than the arm involvement, right, leg involvement is more severe than compared to that of the arm involvement. And another important feature is there will be contractures of the heel cords and iliotibial bands. Okay, there will be contractures of heel cords and iliotibial bands. Right, contractures of heel cords and the iliotibial bands, they occur. And this contracture of the heel cords and iliotibial bands, this will occur by the age of 6 years. Right, this will occur by the age of the 6 years. And in these individuals, if you observe the spine, gradually there will be progressive scoliosis which will develop. Right, gradually there is progressive scoliosis, that is lateral bending of the spine, that will be seen in these patients with the Duchenne Muscular Dystrophy. So these are the clinical manifestations that you will come across. So let me just repeat. One is your Gower sign will be positive. There will be pseudohypertrophy of the calf muscle which is seen. And why is that it is called pseudohypertrophy? Because muscle is replaced by fat and connective tissue, and there is loss of muscle strength which is progressive, and proximal muscles and neck flexors are involved more, and lower limb involvement is more severe than the upper limb involvement, and there is contractures of the heel cords and iliotibial band that occurs, and the progressive scoliosis, it develops. So that will be the clinical manifestations. Then followed by that, if you take the complications, see complications, these individuals, they develop the chest deformity, right? So there is impairment of because of the scoliosis, there is impairment of the pulmonary function. Right, there is impairment of the pulmonary function. And these individuals, by the age of 16-18 years, they are predisposed to serious pulmonary fatal infections. Right, by the age of 16 to 18 years, these patients, right, they are predisposed to serious pulmonary fatal infections. Right, so that will be the chest deformity that you will have. By the age of 16 and 18 years, the patients are predisposed to serious pulmonary fatal infections. And cardiac manifestations, if you see, or cardiac complications, they develop dilated cardiomyopathy. And this dilated cardiomyopathy, right, so this dilated cardiomyopathy, it is a form of heart failure with reduced ejection fraction. So these patients, they ultimately develop the congestive heart failure may be seen, right? And if you see the cause of death, the most common cause of death will be respiratory failure, but the cardiac cause of death, right? Cardiac cause of death in these individuals is uncommon, right? It is uncommon. And if you take the intellectual impairment, even the intellectual impairment is common, right? Even the intellectual impairment is common. Okay, and if you take the IQ, intelligent quotient of these individuals, IQ is one standard deviation below the mean, right? IQ is one standard deviation below the mean. That will be the intellectual impairment in these patients with the Duchenne's muscular dystrophy. And if you take the course of the disease, right? So if you see the, right, when is the onset of the disease, then when is that the individual confined to wheelchair, right? And when is that the individual will develop respiratory failure. So if you see that the onset of the disease will be before the age of 5 years, right? Before the age of 5 years. And when is that this individual is confined to the wheelchair, or and the individual is having inability to walk? The individual is confined to wheelchair and inability to walk after the age of 12 years. Right, after the age of 12 years, the individual is unable to walk and he is confined to wheelchair. And the individual develops respiratory failure and die in second or third decade. Right, in second or third decade, the individual will have respiratory failure and he will have the mortality. And that will be the course of the disease. And if you take the laboratory diagnosis in these individuals, the serum creatinine levels, right, the serum creatinine kinase levels, right, CK stands for serum creatinine kinase levels, they are invariably elevated, right, they are invariably elevated. And how much they are elevated? That is between, right, that is between 20 and 100 times normal. Right, that is between 20 and 100 times normal, the serum creatinine kinase levels are being elevated. And the levels are abnormal at birth but decline late in the disease because of inactivity and loss of muscle mass. So this is very important point. So in early stages of the disease, the serum creatinine kinase levels, they are elevated, but later in the disease, right, late in the disease, the levels may be reduced. And why is that the levels may be reduced? That is because of inactivity, right, that is because of inactivity and loss of muscle mass, right. So these are the reasons why the serum creatinine kinase levels are elevated, decreased later in the disease, right. And if you do a muscle biopsy, what does the muscle biopsy shows? The muscle biopsy in these patients will show that there is degeneration of the muscle membrane, right, there is degeneration of the muscle membrane, and the creatinine kinase levels, okay, so let me tell you, in the muscle biopsy, will be the definitive diagnosis, right, definitive diagnosis is by your muscle biopsy, right, and what will be the biopsied muscle tissue will show you necrotic and regenerating muscle fibers will be seen. right? Necrotic and regenerating muscle fibers are seen. So that will be the muscle biopsy picture in patients with the Duchenne muscular dystrophy. So next, so if you take the creatinine kinase levels, what did I tell you? The creatinine kinase levels, they are elevated, and later in the stage of the disease they are decreased. Okay, and electromyography, it will show you the features of myopathy, right? Electromyography, it shows you the features of myopathy. And if you take the muscle biopsy, as already just now I have discussed, this will be the definitive diagnosis, right? And what it will show you? It will show you the groups of necrotic muscle fibers are being seen. And how do you treat these patients with the Duchenne muscular dystrophy? The treatment is the glucocorticoids, that is prednisolone, right? The prednisolone have been tried, and significant alteration in progression of the disease has been seen with the prednisolone. So whenever you give prednisolone, there was significant alteration in the disease of the individual. So that is a treatment for the Duchenne muscular dystrophy. So to just summarize Duchenne muscular dystrophy, that is the most common form of the congenital muscular dystrophy is Duchenne muscular dystrophy. And in these patients with the Duchenne muscular dystrophy, it is mainly due to the gene mutation, and that particular gene is required for synthesis of dystrophin, right? Then followed by that, it is an inherited disorder. And what type of inheritance? It's an X-linked recessive inheritance. And the presentation is between the ages of 3 and 5 years. The clinical features, they have Gower sign being positive, pseudohypertrophy of the calf muscles, loss of muscle strength is progressive, proximal muscles and neck flexors are involved more, leg involvement is more severe than arm involvement, contracture of the heel cords and iliotibial band occurs, and progressive scoliosis develops. And the complications is that in these individuals, if you take the chest, deformity will be seen, that will be in the form of scoliosis, and because of which they have impaired pulmonary function. And by the age of 16 and 18 years, the patients, they predisposed to serious pulmonary fatal infections. The cardiac manifestations will be in the form of dilated cardiomyopathy and congestive heart failure, and the intellectual impairment will be there in these individuals. The intelligent quotient, right? IQ is like one standard deviation below the mean. And the course of the disease is that the onset of the disease is before the age of 5 years, and the individual is confined to wheelchair by 12 years of age, and the individual develops respiratory failure after second or third decade of life. The laboratory diagnosis is that the serum creatinine kinase levels are elevated in early stage, and later in the disease they decreased. Muscle biopsy is the one which will give you a definitive diagnosis, and what it will show you? It will show you necrotic muscle fibers, and treatment is the prednisolone, where it has shown significant alteration in the progression of the disease. So that completes the discussion of this very important topic, that is Duchenne muscular dystrophy. Thank you very much.